Okay, in this module, I'm going to be talking about best uses of psychedelics. And I put best in air quotes here because the research really is still pretty young. And, I think that the best uses for the moment are evidence-based uses of psychedelics. But I fully expect as the research develops that there would be an understanding about which psychedelics may benefit which disease states a little bit more than others. So I will say that this module is mostly focused on a research precedent or anecdotal reputation of what a psychedelic is good for, but I really expect this ground to kind of shift, change, and evolve as time goes on. It really seems that psychedelics are transdiagnostic therapies, meaning they could benefit many different types of indications or mental health disease states with different types of symptom clusters to them. This is not new in psychiatry. We know that several of the classes of medications we have could have transdiagnostic potential, and particularly the SSRI or serotonin reuptake blocking types of antidepressants seem to fit this bill. They're indicated and or have been demonstrated to have some level of efficacy for things like depression, anxiety disorders, PTSD, and obsessive compulsive disorder. At least there's some others as well. And it seems that serotonergic psychedelics really can also beneficially impact a lot of those same kinds of illnesses or disease states. Where psychedelics may have kind of an edge over serotonergic antidepressants or SSRI types of antidepressants could be the treatment of substance use disorders or addiction. And I'm going to have a module a little bit later that kind of drills down a little bit more into the therapeutic potential of psychedelics for the treatment of addiction. On this slide, you see the best uses of psychedelics according to current evidence. So for MDMA, it's been well studied, or it's the farthest along in clinical studies, I should say, for MDMA-assisted therapy. It also has a reputation for being helpful for couples therapy. So MDMA is perhaps more appropriately termed an enactogen or empathogen, meaning to touch within or to generate a state of empathy, than it is a hallucinogen or an entheogen, or maybe even a psychedelic. It tends to be a little bit softer as far as an experience goes, and this may allow a person that has a severe level of trauma or traumatization to kind of emotionally process things in a more effective way. So MDMA oftentimes has a strongly anxiolytic or kind of fear-reducing quality to the subjective experience. Whereas things like hallucinogens, meaning to generate hallucinations, or entheogen, meaning to generate a state of divine or a state of God from within, are things more like psilocybin, LSD. I would definitely put short-acting inhaled tryptamines like 5-MeO, DMT into this particularly entheogen category as well. And psilocybin-assisted therapy is the farthest along in clinical studies. And the kind of two, I would say, like real leading indications there are major depression or treatment refractory major depression, and then existential crisis, so depression and anxiety associated with a progressive life-threatening illness. And psilocybin also has a pretty strong reputation for being helpful for things like obsessive compulsive disorder, body dysmorphia, potentially different types of eating disorders, as well as anti-addictive sorts of effects, and particularly alcohol use disorder. LSD, there hasn't been as much research in the modern day with LSD as with psilocybin, but you can go back and see some older studies that were positive for alcohol use disorder, and both psilocybin and LSD have a reputation for being helpful for persons that suffer from cluster headaches, and it's extremely painful type of headache. Whereas the dissociative anesthetic ketamine is actually FDA indicated or approved. You're talking about esketamine or Spravato for treatment refractory depression and suicidal ideation associated with depression. There's interest been studying serotonergic psychedelics for different kinds of pain states or pain conditions, but ketamine being a dissociative anesthetic and an analgesic that has a reputation for being helpful for perhaps hard to treat or even refractory types of pain states, things like chronic regional pain syndrome. It also seems that ketamine might be able to provide opioid sparing types of effects in persons that take opioids or opiates. So I would say that ketamine has kind of a better evidence base for those kinds of indications and actual FDA approval if you're talking about S-ketamine or Spravato with treatment-resistant depression and suicidality. So take this module with a grain of salt for the moment because the research really is young. And, personally, working in this kind of space, doing consulting with persons over a number of years now, I'm almost thinking that the rapport with the psychedelic therapist and the kind of set and setting for ingestion could play as big or maybe even a larger role in shaping the ultimate outcomes compared to the choice of substance in and of itself. I think that the choice of substance can be guided by things like current medications and compatibility with a psychedelic of interest, whether changing those medications so that they could be a candidate is actually feasible or not, what other kinds of illnesses a person has, and then I think just what is available and what is legal and what the patient is gravitated towards. Sometimes persons will be really strongly gravitated towards one psychedelic over another, or they kind of suspect or have a hunch that this psychedelic is going to be helpful for them. And I try to allow persons to kind of drive the decision making when it comes to choosing a psychedelic and experiencing a non-ordinary state of consciousness to the extent that is possible.